I'm Gwen, and my presentation is on evidence-based practices for people with schizophrenia. Schizophrenia is a disorder that is identified by symptoms of hallucinations, delusions, disorganized speech, disorganized thinking, grossly disorganized behavior, social withdrawal, diminished emotional expression, and what's called avolition, or lack of self-direction or self-motivation. In order to be diagnosed as schizophrenia, somebody has to experience these symptoms for at least 6 months. Now, that's not to say that somebody with schizophrenia has to have a full-blown psychotic episode for at least 6 months in order to be identified. In an episode of schizophrenia, there are usually precursor symptoms, an episode, and then lingering symptoms after the episode passes. And if over the course of this entire kind of spectrum of events, someone is impacted enough that it affects their home life, their work life, their social relationships, their self-care, that's when a clinician can look at a diagnosis of schizophrenia. Schizophrenia can't be diagnosed if the symptoms can be explained by substance abuse, by other medical conditions or other mental health conditions. It can't be diagnosed if there are cultural explanations. And that's one of the things that the DSM-5 takes time to really identify, that there are cultures for which, particularly in, for example, religious ceremonies, it's common and normal for people to report hearing voices or seeing visions. If in the course of these normal expected events somebody sees a vision or hears a voice, that can't be part of a diagnosis of schizophrenia. Nor can cultural differences in things like eye contact, body language, speech patterns. When somebody's diagnosing someone with schizophrenia, especially if the two people are from different cultures, it's really important to make sure that there's good communication, that words are being understood, and that culture is being taken into account. I once had a client who was diagnosed with schizophrenia because he went to his doctor to complain about bed bugs. He was a monolingual Spanish speaker, and he used the common vernacular for insects when he was describing being bitten by the bed bugs. He said that at night while he was sleeping, los animalitos attacked him. The person who was doing the translating didn't know that that word, animalito, is often used to mean insect, and so she translated it directly as little animals. The doctor heard that his patient was thinking that he was being attacked by little animals at night, and suddenly my client was on an antipsychotic. Schizophrenia as a condition is notoriously hard to treat. Of the people who receive treatment, about 20% experience full remission of symptoms. That means that for 80% of people who are receiving treatment for their schizophrenia, they will continue to have some form of the illness, experience some symptoms, even if they are completely adherent to their medication and to their treatment. This condition is so difficult to treat and is so nuanced in its treatment that in 1992, the National Institutes for Mental Health and other government organizations came together to jointly fund what was called a PORT, P-O-R-T, which stands for Patient Outcomes Research Team. This PORT met for the first time in 1992 and has met every few years since to make recommendations about the most effective treatments and the best evidence for treating schizophrenia. And over the years, their recommendations have changed. Always, there has been a recommendation of treating with antipsychotics. Which medications they have recommended, how they've recommended the medications, what they've guarded against has changed over the years. But their most recent recommendations came out in 2016, and basically what they've found is that antipsychotics kind of across the board have about the same efficacy no matter which antipsychotic you use, and they all have some level of side effects that cause problems for the people who take the medication. but ultimately what they found was that there is very little difference among antipsychotics. They also found that antipsychotics are effective in treating some pieces of the symptomology for schizophrenia. Antipsychotic medications are generally effective at addressing hallucinations, delusions. They are often impactful in helping people overcome comorbid problems like substance abuse that comes along with a diagnosis of schizophrenia. Where the antipsychotics are less effective, and the portions of the diagnosis of schizophrenia that are most treatment resistant are what are called the negative symptoms. And those are the symptoms that are defined by the lack of something. That's that social withdrawal, the diminished emotional expression, the lack of motivation or self-direction. And in their 2016 recommendations, what the Port talked about in addressing those pieces, those negative symptoms of schizophrenia, were behavioral interventions like cognitive behavioral therapy groups, token economies that reward people for participating in their communities, in their relationships in pro-social ways. They recommended specific programs like community involvement and intervention, like job coaching and employment training that help people stay engaged in their community despite their diagnosis. The recommendations also included family involvement, specifically psychoeducation and cognitive behavioral therapy for those who care for and love people with schizophrenia. One of the realities that the Port acknowledged in their recommendations in 2016 was that part of an effective treatment for schizophrenia is just simply helping patients learn how to live with the disease. The treatments that have been recommended for schizophrenia seem to work well across everyone who is diagnosed with the disease, whether that's someone who is young, who's just been diagnosed, and people are diagnosed young. Most people are diagnosed in adolescence or in their 20s. The peak onset of first psychotic episode for men is usually in about their mid-20s, and for women is in their late 20s. And generally for most people, it's a disease for which they will have symptoms for the rest of their lives. And the treatments that the Port recommends seem to be effective across people who were just diagnosed, people with more severe symptoms, and older people who've been living with the disease for a long time. One of the real barriers to effective treatment for schizophrenia is adherence. When we talk about adherence, we're talking about somebody being able to actually take their medications, being able to actually participate in their psychotherapy and their treatments. And part of the reason for this makes sense. The nature of the condition is such that when it's defined by disorganized thinking, by lack of motivation and lack of self-direction, it makes sense that one of the big hurdles is that people just simply can't adhere to the regimens to stay stable and to stay asymptomatic. This is where the recommendation for community involvement comes in. The Port had recommended more community involvement, which really means community mental health centers being more involved in monitoring, coaching, encouraging. Unfortunately, historically, community mental health centers just simply don't have the resources to be able to provide the kind of mentoring and coaching and support that's needed for true adherence to a medication or behavioral regimen. In 2012, though, there was a promising study using technology to help people adhere to their treatments. It was a small study. 55 people with a diagnosis of schizophrenia were given cell phones. And using those cell phones, they received text messages, multiple text messages a day, that reminded them to take their medications, that encouraged them to cope with their delusional, their auditory delusions or hallucinations, or their visual hallucinations, that encouraged them to participate in pro-social activities. And what they found was that for 86% of the participants in the study, there was some positive effect. The greatest positive effect was for individuals who lived alone. Those people reported diminished hallucinations, increased positive social interactions, and increased adherence to taking their medication. People who didn't live alone reported decreased hallucinations and increased positive social interactions. Now, there was a 14% contingent of people for whom this was not an effective intervention, who were not able to complete the study. And those were the people for whom the symptoms were significant enough and they were enough cognitively impaired that they simply could not follow the instructions and participate with the technology. But for those 86%, the study showed real promise. As the port continues to meet and to look at studies, hopefully there will be more and more of this merging of different ideologies. There will probably never be a time when antipsychotic medications are not used in the treatment of schizophrenia. It has always been a part of every recommendation. Even when cognitive behavioral therapy or other therapies are recommended, it's always in conjunction with medication. But by taking the positive effects of medication, the positive effects of psychotherapy, and using creative approaches like technology, like community involvement, like employment coaching, and ways to motivate people to get out into the community, hopefully we will continue to learn more and to gain more understanding and have more success in helping people with schizophrenia live healthy and productive and happy lives. There is a written version of this report also attached to the discussion board post, as well as a list of resources if you're interested in finding out more about evidence-based practices for schizophrenia. Thank you.